Welcome back to Taking Charge of My Cancer podcast, episode 73. I have an honor to have with me an amazing speaker. This is Dr. Cherylle Hayes. Dr. Hayes earned her undergraduate degree in nuclear medicine technology and health physics. This area of study piqued her interest in patient care, and she went on to earn her medical degree at Medical College of Georgia. While there, she completed her residency in radiation oncology and became a board-certified radiation oncologist. While Dr. Hayes has interest in several areas of oncology, she's particular interest in breast cancer treatment, cancer survivorship, and quality of life issues such as eating healthy and maintaining a consistent exercise program. Dr. Hayes has researched and authored in many professional journals and especially on issues related to gynecologic oncology. She had published a book chapter on pain management. Locally, Dr. Hayes has served on the boards of several community organizations, including the American Cancer Society, Lifestyle Blood Bank, the Advisory Board of Gainesville Health and Fitness Foundation, and the University of Florida Perform Arts. She also participates in local and national societies, including Astro, Acro, AMA, and the American Brachytherapy Society. Prior to coming to the North Florida Radiation Oncology team, Dr. Hayes served at the University of Florida as an assistant professor. So again, thank you so much for being with me this afternoon, Dr. Hayes.
Thank you, Durley. I so appreciate your invitation.
Thank you. And again, I hear great things about you, and I really appreciate all the, sometimes, physicians can just do, so physicians have two ways to do things, and this is in general. They either kind of like, okay, this is what I'm gonna do for your cancer, and this is the, this is the possibilities or the secondary effects, and this is the plan. And then we're gonna do simulation day this day, and you're gonna come here and see me, 6 weeks every day, see you later. And the nurse is gonna tell you about what's happening with education. And then you have the physician who actually take the time and listening and really explain things in detail and make sure that the patient is pretty much kind of like have their own decision making, and this is the options, and it's really I'm giving you the options and I'm giving you the pros and the cons, but you have the ownership of your own journey. So you're one of those. So like I said before, I hear great things about you all the time, and see great outcomes from your patients. So thank you for being that type of physician. I really appreciate it.
Well, thank you. Thank you. I actually consider myself very old-fashioned in that way, because when I do see a patient, I do like to give them their diagnosis. I like to give them their stage of disease currently while I'm seeing them. It could be a clinical stage or a pathologic stage, which is done at the time of surgery. And then maybe their options from there and some of the clinical trials that are going on. But better yet, we write that out for them so that they leave with an educational sheet defining for them their personalized diagnosis and their personalized treatment options. So important for patients today to look them in the eye and tell them, hey, I've got you. I know this experience. Not only do I personally know it from my own family, but also just from treating so many patients over so many years, what the needs versus what the wants are. And it's so important to be able to look somebody in the eye and know your audience. That's, to me, one of the biggest things. I think I treat people who are crying, people who are stoic and don't have any questions, people who are excitable. And you have to know your audience and know where you can take somebody to the next level.
Yep. Yeah, that's super important. So tell me about your mission and were you always planning to do this?
Well, actually, I was planning to be an orthopedic surgeon.
Oh, wow.
I was heavy into sports as a child and had a little hiccup with scoliosis and wore a Milwaukee brace and had to see an orthopedist once a month. And I thought, oh, that's a cool job. I want to be an orthopedist. So as I studied in medical school, I went through oncology and forensic medicine. And I thought, wow, these two things are the top of my list now. And then as I got into the biology of cancer and how different it is, I hear so many times in the community, cancer could be cured. It's easy to cure. And I think people really just don't understand the cellular changes that occur in our bodies every day. Every day we have inflammation. How do we offset that? Every day we have cells dividing. How do you offset that? how do you offset a normal cell that goes AWOL, which is the definition of cancer, when you're made of 37.2 trillion cells? It only takes one. So those are some of the things we deal with on a day-to-day basis. And I ask every patient who comes in, how many cells do you think you're made of? And you would be surprised at all the answers.
Oh my
So
God.
my path was to provide compassionate care and personalize the care to the patient so that they understand what they have, not what everybody has, not what Google tells you you could have, but what do they have individually.
Okay, that's amazing. And then you mentioned, or we talked a little bit about this before, you have a personal story with cancer as well. Would you like to share it with us?
Sure, sure. So, when I started studying, I actually did a breast fellowship at Emory at university. And when I started at University of Florida, while I was going into the studies of breast cancer with one of my idols, Dr. Nancy Mendenhall, who has been there for many years, um, I learned that my sister developed breast cancer. She found a knot in her breast. She was in her 30s, not the time that you get a baseline mammogram, no family history. And she ended up being diagnosed with early stage breast cancer. We did not have the data that we have today. So she was not told anything differently other than having surgery. She'd be taken care of, maybe a little endocrine therapy for 2 years, not 5. And so basically, when she got pregnant, her cancer came back fulminantly. She had widespread metastatic disease, and she lived out the next 14 to 16 years with us managing her care and her doctors in California. She was an opera singer as well as a lawyer at that
Wow.
time.
Wow.
Since I've had an aunt in Florida diagnosed with breast cancer. My mother has melanoma. I have another aunt who's passed away from breast cancer. So what I've learned is the biology matters and genetics matter. And so genes today, if you look at all the standard of cares, even with breast cancer, just singling that out, genetics are so important. And now we're testing every woman under the age of 65, and it's now in the NCCN guidelines. So
That's
yeah.
amazing. And it's so important, sometimes, and it's amazed to me when I got exposed for the first time to the oncology world was over 15 years ago. And the things that we used to do then versus the things that happen now, not only from like the trials and not only from the breast surgery, even from the radiation. I used to be able to go to like their radiation meetings sometimes and then try to understand when you guys talk about, the beam and all those things to try to figure out in my head all these kind of heavy terms. And then you're like, oh, I think I get this down pat, 6 weeks, every day for 6 weeks. And now it's like all these different protocols, this patient can be 3 weeks, this patient can be every other week, this patient can be, so I'm like, I giving up, like I cannot keep up anymore, but it is exciting. So it is nice to figure out that do we really need to give that much toxicity to somebody if they don't need it, right? Because it's the same
That's
survivorship. So
right. Today, I think what happens sometimes is we scare patients and they feel like they have to do everything. But I think if you sit down and explain some of this information that's coming out of these clinical trials, some women don't even need radiation. Even some women who have node positive disease, based on the biology, some of them don't need radiation. And so we now know we are testing certain trials that have lower doses, that have lower fractionation schemes. So maybe a 3-week scheme equals a 6-week scheme radiobiologically. But the patient now doesn't have to come for 6 to 7 weeks. They can come for 3 weeks with equal outcomes and less toxicity. What about protons versus photons? We have a clinical trial evaluating protons for left-sided breast cancers. Can we really reduce the dose to the heart and have meaningful outcomes that are, if not equivalent, better to what we've been doing? And today we have better techniques, even with intensity modulated radiation, image guided radiation, many, many techniques coming down the road. And all of these things are based on our current clinical trials. And you're absolutely right. A woman needs to know what are the options and where do they fit in that scale of those clinical trials. For example, DCIS, that's a pre-invasive lesion. It's a stage 0 lesion. They all don't need radiation. And we now have a genomic test called Decision RT that actually can look at the biology of their DCIS. That stands for ductal carcinoma in situ. The way I like to think of that is ductal cells inside the duct. DCIS hasn't broken through, ductal cells inside, and it's stage 0 with the risk of lymph nodes 0 to 1.5%. And, do we need to treat them? Or can we get wide local excisions with negative margins and call it a day if they take endocrine therapy and can tolerate it? So many things coming down the pike with looking at toxicities, and not only toxicities, but quality of life. Women go through so much. They are the wives, the sisters, the daughters, the caretakers, the homemakers, the business women that do a little bit of everything. And how do you mix getting a diagnosis in with all of those other chores? That is really what it's about when women unite on these kind of topics.
Yeah, that's such a great information right there, Dr. Hayes. This is so exciting. So what good resources would you advise patients to look into?
Oh my gosh, there are so many resources, but I guess one of the biggest things that I worry about are women getting online and just reading everything. And that's a very scary proposal, but there are some really good resources. You've got the National Cancer Institute, which, as you know, UF is now one of the top 5 National Cancer Institute accreditation in the state of Florida. The American Cancer Society, Live Strong is actually a good place. Cancer Support Community, very good online help. Patient Advocacy Foundation, very good. Florida Cancer Specialists Foundation, very good. So you've got some good resources. The question really becomes, how do they focus on resources for their needs? That's where you have to drill down. That's where patients have to individualize their needs versus what is the needs of a typical breast cancer patient. Very different for each person. So many, many resources. Those that I named, even Susan G. Komen, I'm sure you've heard of that. That foundation has been around for a while. I will tell you, the most valuable thing I have found locally for every individual woman is to see if they have a navigation program at the cancer center that they're involved with. Navigators are wonderful. They can lead you in the right direction. They can educate you. They can help get the doctors involved with education. They unite the teams. Very important. That's probably the number one thing I would do, is to look for a navigation program.
That's a very good point. And you're right. We have been coming across some patients coming from other institutions, outside Gainesville, who didn't have that, right? And they come in here, and what our nurse navigator does is amazing. It's like it's 1 point for everything. It's amazing. Like, they just make sure that they see you as a physician, that the referral goes on, that the patient needs are being met, that the referral for mental health, physical therapy, occupational therapy, social worker, any of those things is really amazing, the job that they do. You're absolutely right.
And I don't know if patients really understand how many people get involved. You have a surgeon who will tell you about the surgical needs, a medical oncologist with all the new data coming down now about immunotherapy, targeted therapy, the newer chemotherapeutic agents, the less toxicity we see now with these kind of drugs and women on these medications. So much coming down the pike that not only do you need to meet with these people individually, but you need somebody to help be your patient advocate and help guide you in all these decisions.
That's very good. Well say. How about 3 valuable tips that you have that could benefit my audience?
I think the biggest tip, and I do a talk on this, I've done it around the country for many years in the past, being the CEO of your body, or the president of your body. You can veto anything. You can decide what you will or you won't do, but a president needs to know the information that they're signing off on. And so if you're that's the number one thing, is being the CEO of your body. The next thing I would say is seek support. Who is the key support system? Women, I think, lean on women more so than leaning on their husbands or men in their families. So I think having a good friend. For men, I always say, grab your wife. They're mostly the caretakers, but also grab somebody that can acknowledge what you're going through. Maybe another patient that's been through what you've been through. And I think the last thing I would suggest for anybody is communication is key, but self-care is probably number one. I just told you that being the president of your body, but that's part of self-care. All of us lack it. You probably lack it. I lack it. I get up at 5 and I'm like, now, am I supposed to work out? Or am I supposed to go to work? Am I supposed to look at something? And I think we all go through that. When are we going to find time? And I always say, spend 10 minutes at a minimum and up to an hour a day focused on yourself and focused on your mental health and your self-care. That means no children can be around, no husbands can be around, no dishes can be around, no work can be around, focusing on you.
Yep.
That's really hard for us to do, especially in the US. Our society is so geared to go, 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 go.
Yeah, you're absolutely right. Yeah. You're absolutely right. I think that's so important. And sometimes we don't even do that. Like I try to do my best in doing that. And to me, working out is super important. It's how I kind of get my stress, is my caffeine of the day. So and then I think that you just have to become more like disciplined, right? Like I always tell my patients, I say, you come to these appointments and I'm gonna discharge you because you're doing really well, but I want you to continue on a wellness program, but you need to make sure that you had an appointment with yourself, right? So
Right.
4 o'clock in the afternoon or whatever time it is, nothing gets on the schedule because it's your exercise time and
Right.
nothing is gonna get in the way of that. It's as important that you go see Dr. Hayes, as important that you go see your breast surgeon. It is an appointment that it is with yourself and you gotta respect that and then work around that, so.
And I think one of the other things is we have to take everybody's personal stories into account. So if you're a single parent and you have to be home for your child, well, there's an app now on phones called Seven. It's a 7-minute workout. There's a variety of levels. It's free and it's a great workout at home. Also, if you're going to the lymphedema, a physical therapist who specializes in lymphedema prevention and education, utilize those exercises. Going to physical therapy and utilizing any exercises they give you at home. I think that it's very hard for us to be self-disciplined in our lives, to go home when you feel good, like just getting home and relaxing, but spend some time focused on yourself. It improves outcomes in cancer patients, but better yet, it improves our mental health.
Okay. What is a common question that you find oncology patients have, and will you share that information today? Like when they come to you, what is the first thing that you think, like, patients tend to ask you?
Yeah. So I think the very first thing is, what did I do to get this? Like, did I cause this?
Yeah.
And I hear that so frequently. And I'm like, you didn't do anything. I am actually treating an athlete right now. And she goes, I eat well. I don't eat any meat. I am a plant-based girl. I'm a swimmer. I don't understand how I could get this. Well, 65% of breast cancers are sporadic. We don't know why they can occur. We know there's environmental issues. We know there's genetic issues. We know that food can be an issue. And so how do we balance all that? And so I try to explain to them where cancer come from, how does it start, and where does it begin? Like, what is the initiation of a cancer cell? And what do our genes say about that? So everybody's got genes from their mom and dad in their cells. But when a cell goes AWOL, which is the definition of cancer, a normal cell that starts to regulate cell division on its own, doesn't listen to your body. When it does that on its own, what is the initiation? How can we control that from that point on? So I think that's one of the most common questions. I think the second most common question is, am I going to die from this? Am I okay? Am I going to live? What do I have to go through to get through this? And I think that's a combination question that, the first thing you do is put calm to their storm. They have to understand. And if they educate, if patients are self-educating, or the physicians or their teams, the oncology care teams are educating them, they're going to do so much better. So much better.
Okay.
The outcomes are better.
It is some, I don't know if we want to call it myths, but I get this a lot from patients like, well, they told me in radiation that I cannot use deodorant, or they told me that I cannot use anything, no soap or no cream or nothing before radiation. So you want to tell us a little bit about that?
Yes. So radiation is a way that we treat cancer cells to stop them from replicating. How it works is we put regular x-rays and we aim them and we conform them and we try to get rid of normal anatomic structures, normal anatomy. We try to pull all that out of the way. And the reason we tell people not to have anything on their skin is because we can increase the dose to the surface by adding anything on top of the surface of the skin. And that's not what you want to do when you're treating the breast. However, when we treat chest walls, in other words, a woman's had a mastectomy and they require radiation, we actually put something on their skin to increase the dose. It's called a bolus. And that's the effect you get from creams, lotions, potions, deodorants. If people are putting on a lot on their skin, it's actually increasing the skin depth. And that's why we tell people don't have anything on before coming in, because the dose to the skin will be increased. That's essentially the basics of why we tell people not to do that.
Okay, got you. So they don't do that at all through the course of radiation and they just wait until after work, even deodorant?
Well, what we tell people is afterwards, like an hour after radiation, I tell people apply a cream. We have a list of them, creams without alcohols, without glycol. Sometimes I tell coconut oil. Sometimes I say I'm Greek, so I like olive oil. I say you can use olive oil. You can use Eucerin. You can use Lubriderm. There are many lotions that can be used to keep the breast moist, because radiation can cause dry desquamation or the skin to become dry, and that keeps it moist and it decreases the risk of side effects. Today, the way radiation is delivered, we have less skin toxicity as it is. And now, with examining protons and IMRT and IGRT, we are seeing less and less and less side effects.
Okay, great. Um, what books recommendations do you have for the audience and why?
So I'm going to give you one of my favorite books I read many years ago. For some of the younger audience, they probably don't know Gilda Radner from Saturday Night Live. She was years ago. She was Rosanna Dana, and was very funny. She developed ovarian cancer way before we knew genetics played such a big role. And she wrote a book. It's an autobiography, and it's called "Oh, It's Always About Something." What a great book. So autobiographies, you probably see a lot of newscasters today on ABC, NBC, all who have had breast cancer. We've had many autobiographies published that are very good. Even in Gainesville, we have exercise therapists and people who are publishing books, very good. What I like about Gilda Radner's is going through all these tests that we all have to go through in our lives, that she puts a fun spin on it. Like, why do I have to do this? And then she explains in her own words, why should we be laughing at all the things we go through in life? Men and women are so different, children are so different. And so, how do we individualize that? And that's what she did in this book. So, I would tell you that is one book. Some other serious books, Breast Cancer Survival by Doctors Link and Washman is a very good book. Gynecologic cancers, there's What You Need to Know About Gynecology and Cancer, and that's a very good book. There are just so many, but if you really want to know what book I would read first, it is Gilda Radner's. It's not on breast, it's a gynecologic diagnosis that she had, but it really is enlightening to know that you don't have to take everything so seriously. Some of these are steps that we go through to ensure that the disease is localized. Maybe if the disease is not localized, that it hasn't progressed. And those are the things we put people through every day. And believe me, I laugh with my patients every day about all these things. And I try to relate personally as well as with my sister and all the things I went through with her. And so we try to bring it back to being human again.
Right. Now you mentioned gynecological cancer. Let's touch a little bit about from the radiation standpoint on gynecological cancer. What would you consider one of the major side effects from the radiation on women that go, that are dealing with gynecological cancer?
Yeah. Well, we've come so far, even as I said in breast, we went from 6.5 weeks to 3 weeks, and now we're even looking at 5 days a week. We're looking at 1 day a week, 1 day, one treatment. We've got ultra hypofractionation trials. We're looking at all that right now. As the technology has improved, we're able to be more conformal, more dose targeted to where we want it to go, and less dose to organs at risk. And so the toxicity profiles have come down. Well, while immunotherapy and chemotherapies have improved for gynecologic cancers, for example, ovarian cancer and early stage diseases doesn't even get radiation anymore. Much like some of the breast cancer patients who we look at genomics of their tumors, they don't require radiation. So I would say side effects are for uterine cancers where we're having to treat the whole pelvis, and maybe they get diarrhea or loose stools. Maybe a little urgency with urination, but with intensity modulated radiation, we now can carve out doses to bowel to bladder to the femoral head. So we don't see the same side effects. Fatigue is always the most common side effect I see. Disruption to your day is always fatigue taxing. It's emotional, it's multifactorial. You got to get to your job, or you've got to get somewhere else, or you have your life upended with the diagnosis. I think all those weigh into it. I think vaginal cuff radiation, we do it for uterine mostly, and that can cause vaginal stenosis. It's the most common side effect, vaginal dryness. And we have remedies today for that, that really the toxicities have been so minimized.
So what is your advice for the pelvic health physical therapies? Like, what's a point that we were doing kind of like dilators during, and then we move away from it, and then just doing it afterward, because it seems like the stenosis will happen more afterward. And then we knew that in the beginning, maybe that was easy for them to use, a dilator, but then that got to the point that was just that's too much irritation to be able to use it. So what are your thoughts on that?
Yeah, so I agree with you. We have just like physical therapy is so important. Let me just make a comment about physical therapy, because many people blow it off and they say, oh, it's nothing, it's not going to help us. But many times we're deconditioned after surgery and we don't know it. When you lose weight, you lose muscle mass and you don't know it. And sometimes you don't know what you can or can't do. So specialized physical therapy can really help put a calm to that storm of not knowing, like, what should I be doing? Or what can't I do? What can cause more harm? And so I think, let me just point out that physical therapy is really important as a part of the integral chain. As far as what I recommend, so we used to tell people, just like you said, Durley, that we used to recommend vaginal cuff inserts during radiation. And now what we've done is we said, okay, inserts or dilators, they are interchangeable, that we wait until a month after radiation. Why do I do that? It puts a calm to the storm. The changes cellularly occur months after. And so it gives a woman a chance to get over their treatment, to put some sense to everything in their own mental health. And then it allows them to come back with a calm, saying, okay, now what can I do to prevent further issues down the road? This is all about quality of life initiatives and about optimizing not just your cure, but your quality of life on a daily basis. And that's what's important. You can cure 100 people, but if I cause a lot of problems all down the road, defeated bringing people in, really.
Yeah.
So I feel that if you're diagnosed with cancer, the first thing to do is to get a calm to the storm, understand and educate yourself. But then how do you stave off symptoms? I'm huge on that. That is like one of the biggest things I talk about is, well, if I'm going to cause this, every week you're going to see me because I want to prevent any side effects from occurring. Very important. So going back to the question is, I have delayed using vaginal dilators. It is important because you do get proximal vaginal changes with not just external beam radiation, but also with the implants we do. And so it's really important to understand timing of everything. And that is an education in of itself for patients to prevent side effects from occurring, and should be discussed with them by their physicians before treatment.
Okay, great, great. So do you usually refer everyone to physical therapy, or when do you make that referral to physical therapy?
100%, it should be done preoperatively. So I defer to my surgeons. And in fact, we are NSABP accredited. And these organizations are now pushing that everybody is seen up front. Why? Well, the first thing I tell people, I've had women come in and go, I just want my breast cut off. I want to be cured. And I try to explain to them, breast saving surgery is equivalent to a mastectomy in most cases for cure. The only purpose of breast saving surgery is to leave a cosmetically pleasing breast with equivalent survival to that of a mastectomy. So before they are going to head on to a surgeon, if they see me first, or after they see the surgeon and they see me, I said, the first thing we're going to do is go to physical therapy. We're going to talk about lymphedema, how to prevent it, how to educate yourself on what you can do at home, or when you're going to fly in a plane, or when you're going to go somewhere, with a different pressure, or to understand what my options are. And then how does physical therapy or any other ancillary service fit in that I need to make an important priority in my cancer journey?
That's excellent. We love you for that, Dr. Hayes. And sometimes it's so hard to, I don't know if it's just because it's just the system, it's just the surgeons are just so busy try to get patients and worry about like, how I'm gonna try to cure you from cancer, or how can I avoid for this to continue spreading out, that sometimes we don't see the whole quality of life. So we really try to, you're right. I mean, we can see everyone pre-op. We can do so much more. And even the education, right? We find that somebody can be overwhelmed because you just have a cancer diagnosis, and it's a lot that goes with it. But at the same time, I think that, we get to explain and reinforce what you as a physician has been already explained to them. But it's so overwhelming for them that they're not only catching like one thing, right? Out of the 5 things you're explaining. And so when
Right.
they come to us, we have the opportunity to explain more in detail and then say, well, this is what can happen. That's why we're going to see you 2 weeks post-op. And that's why we're here with you, and we're going to walk besides you to help you along the road, to just make
Right.
sure that you're having the best outcomes on quality of life out of all this, regardless, right? So,
Right. And one of the things I hear really since COVID, as I'm sure everybody across the state of Florida has recognized, the staffing shortages have made it tough, and it's made it tougher on doctors. You have doctors acting as nurses and doctors and secretaries. You have nurses acting as doctors and secretaries, and it's become a very different world in the medical world. But I would tell you this, I would not proceed with surgery if I didn't understand what my options are. And that is the biggest thing you could tell a patient today is, listen, take a step back. One day is not going to make a difference. 1 week is not going to make a difference. Understand your options. Understand what you can do to prevent bad outcomes and side effects, because optimally, the surgeons don't go home with the patients. Any of the doctors, the PT, the OT, the nurses don't go home with you. You go home and live complications that can occur. And we want to prevent that. We want to give you the best life ever and keep your work life, your personal life, your family life all intact. That's the goal. And if somebody gave me that and said, listen, I want you to have the best life ever, that would be so meaningful to me. And that's what I project onto patients, that this is a bump in the road. A lot of people go, I'm not unhealthy. I go, well, you're not unhealthy. You're actually really healthy. You have a bump in the road with cancer. We got to take care of that and then get you moving on in your journey.
Very good. And then I wanted to ask you this. I have a couple of patients who mentioned there was a paper that just came out a couple of weeks ago that I'm really excited about. And I keep hearing a lot in our tumor boards all the time, discussion between the radiation oncology and our breast surgeons talking about, this paper, which is, omitting axillary dissection in breast cancer with sentinel node metastasis. So you want to tell us a little bit about that, and then what is can really change so many things?
Yes. So that came out in the Lancet on April 4th. And it's a very big paper that helps bring it to fruition. But we've had other studies actually before that, called the Z11 trial, that actually looked at women who had 1 to 2 positive nodes. And we call these sentinel nodes. The sentinel nodes are the first lymphatic drainage pattern that occurs when we inject a tumor and it drains to the lymph nodes. We try to take out 3 of those sentinel nodes so that we can assess them for spread of disease, otherwise called metastasis. But what we have found is that whether those nodes are positive or not, even with macroscopic disease, that means disease over 2 millimeters inside the node, that we no longer need to go back and take all the nodes under the arm. We call those level 1, level 2 axillary dissections. We don't always need to do that because the outcomes are equivalent. If you're going to get radiation, the outcomes to radiation with a sentinel node biopsy alone versus radiation with sentinel node plus an axillary lymph node dissection, there's no difference in outcome. They are equivalent outcomes, and it actually it wasn't statistically significant, but the outcome was actually a little better with a sentinel node biopsy alone. That means no axillary dissection and radiation. It was about a 1 to 2% difference that was better in that arm. My point is, I always tell all my patients, listen, your surgeons are going to tell you, we're going to do a sentinel node biopsy. And if it's positive, we're going right to an axillary lymph node dissection. I tell them, no. You need to ask. You need to stop right there and say, well, if I'm a candidate for radiation, or if I'm a candidate for further management, is it going to make a difference to my outcome? Because lymphedema is much higher in the axillary lymph node dissection. Not only is it edema, which can be life altering. It's also deformation or deformation of the shoulder, decreased mobility. You've got pain. So other things can come down the pike with that. And all these need to be addressed. What I think medicine is getting better at is not just the technology, but the research is now able to be developed in shorter times. So we're able to see now that the research is moving the needle much quicker in many fields. So we no longer need to do such exacting surgery. We don't have to cut everything out. We don't have to cut extremities off for sarcomas now. There's so many things coming down the pike. What I will tell patients today is less is more.
Yeah, yeah, that's great. So how can people find you, Dr. Hayes?
You can reach me on my email, which is cherylle.hayes@hcahealthcare.com. You can call my office. If you leave a message, I call everybody back, except you, Durley. I know it took me a while to get back with you. But my office number is 352-333-5840. You will get a call back by me personally. And the other way is my personal email, and it's CherylleAnn@gmail.com. And I will leave all those with you, Durley, so that you can reach me or have anybody reach out to me at any time.
Absolutely. And I will add those to the show notes. Excellent. Is anything else you would like to share with us for wrapping up, Dr. Hayes?
I think the biggest thing for everybody is to be your own advocate. Be the president of your body and the CEO of your body. You can veto anything, but you can also accept a lot of other things. Make sure that you've got balance in your life. I will tell you, I do not have work-life balance, and I hear these younger physicians coming out that is their primary focus. And I said, well, they may have it right, but be focused on yourself. Don't be focused so much on everything else going on in your life and listening to all the noise. Be focused on your wants and your needs, and be focused on taking care of yourself so that you can take care of others. And I always go back to an airplane. You put the oxygen mask on yourself first before you do your child.
I love that. That's a great way to finish it up. That has been amazing information. I really, really appreciate that. Was super fun having you with me today.
I look forward to working with you in the future.
Okay. Thank you, Dr. Hayes. Have a great rest of the afternoon.
Thank you. You too.
Okay. Bye.